He is also honorary professor of the Università della Svizzera at Lugano. He was made commander of the most excellent order of the British Empire by Her Majesty Queen Elizabeth II in 2019. He is also the High Sheriff of Nottinghamshire in nomination to assume office forthcoming in 2021. He is right now the editor-in-chief of the Journal of CORNEA and the president of the European Association for Vision and Eye Research Foundation, as well as member of Academia Ophthalmologica Internationalis and the American Ophthalmological Society. He's been the past master of Oxford Ophthalmological Congress in the UK. He has, umpteen number of posts under his cap. He has been the president of the Royal College of Ophthalmologists, UK. He has served as editor-in-chief of the BJO, the British Journal of Ophthalmology. He's been the president of CORNEA, the president of the European Association for Vision and Eye Research, and the EVER Foundation. So with all this, I give you Professor Harminder Singh Dua. Welcome, sir. Welcome to our program today.
Thank you so much. One should always worry when the introduction is longer than the talk. So thank you very much for those kind words, and my very best wishes and greetings to all members of the MOS. And I'm honored for this invitation. It's my pleasure to speak to all of you on the topic that was signed, which is corneal trauma, abrasions to lacerations. So I'm going to try and get my slideshow going, and that seems like it's up now. So what we know about trauma, we divided broadly into mechanical and chemical. Mechanical is abrasions, recurrent erosions, foreign bodies, and lacerations. So I'm going to cover the mechanical part of this topic today. The first thing which I find, everybody, many of my colleagues who are non-cornea specialists and many of the juniors, if you ask them the difference between an abrasion and an ulcer, they struggle. So abrasion is breach of continuity of the epithelium or mucous lining. So what's an ulcer? Another breach of continuity, yeah, but what's the difference? And the difference is that in an ulcer, you need tissue necrosis and sloughing. If there is no tissue necrosis or sloughing of the associated, whether it's epithelium or stroma, then it's an ulcer. So we're talking about abrasions today. And abrasions with trauma, the point I'm making with this slide is can occur with blunt trauma as well. So this was a baseball bat, a glancing blow to the surface of the eye, and you can see the edges are not as clear as when it happens with something sharp like paper or fingernail. So, but this is nevertheless an abrasion. So whenever you see an abrasion, you try to ascertain what was the cause, how extensive is the injury, how deep it is, and we tend to treat it with lubricants, prophylactic antibiotics, bandage contact lens. We tend to always check the corneal sensations, usually on the second day, because the first day before you've thought about it, you put an anesthetic drop to get the patient to open the eyes. So you don't get the chance to check the sensations. When check it, because often you'll find there's an underlying neurotrophic element, and look for other features of the injury, because it may not just be the cornea, and a blunt trauma, as you know, can affect all the structures right back up to the optic nerve. The question here, which is slightly controversial, is what prophylactic antibiotics do you give because of the risk of resistance? And this applies across the board whenever we're using prophylaxis. I tend to use chloramphenicol. It's a bacteriostatic agent, and the risk of resistance is low compared to using your first-line fluoroquinolones, which will be useful when there is frank infection rather than doing prophylaxis. But whenever there's an abrasion with a bandage contact lens on the eye, you're increasing the chance of infection several-fold. So the bandage contact lens gives you some relief, but you must use a prophylactic antibiotic in that sort of circumstance. Remember, acute hypoxia due to prolonged contact lens wear, and usually the soft contact lenses, can cause ischemia and loss of surface epithelium, which will look exactly like an abrasion, but the extent of redness and the extent of stromal edema can be a lot more. This is part of this CLARE, which is contact lens associated red eye. But you treat it with a lot of steroids as well as all the rest that I've just told you above for the abrasion. But the steroids here help recovery of the endothelial cell function, which is also affected in these situations. Right, so moving on, when you have corneal abrasions and they heal, particularly with trauma secondary to organic material, you end up getting microcysts. I'm not sure if you can see my pointer. If you can, then you see these cysts in the bottom right panel. There are some fine microcysts, and if you take an enhanced view, you can see these are intraepithelial cysts. These are very subtle classic signs of the reason for recurrent corneal erosion syndrome that occurs after trauma, not necessarily associated with the dystrophies where, like map-dot fingerprint, it's a slightly different mechanism. And when you see that, then that's the area that one has to treat. When you get recurrent corneal erosions following trauma, the definition of one is that it's a spontaneous, painful breakdown of the corneal epithelium, usually on waking, and there's positive and negative fluorescein staining. So you can see over here the area of negative staining, and there is the area of positive staining in between. And again, the treatment for this can be varied. It can be also quite varied in its manifestations. So here's a huge sheet of epithelium that is torn off, and sometimes you have a single dry spot. So repeated blinks, and only that spot, the tear film breaks up rapidly, then you know that's a dry spot, as against random breakup at different places. There's again a very large one with negative and positive staining. Yet another one you can see. So when it is slightly off visual axis, the treatment I used to do in the past, I don't do anymore, was anterior stromal puncture. You can see if you're doing this, the density of the punches has to be quite close, and you do multiple, but some of them will leave little scars behind, as you see over here. So that's why I tend nowadays to do alcohol delamination as my choice of treatment for most cases when we come to the interventional stage. But before you come to the interventional stage, you use lubricants, you use a bandage contact lens, and then PTK, diamond burr polishing, or alcohol delamination, they're all within the same sort of efficacy range. The success rate is the same, but alcohol delamination gives you tissue for histology and is not as expensive or involved in terms of technology as a PTK, which is a phototherapeutic keratectomy. Sometimes it's iatrogenic. So this is a lady, just to mention, she had a glass injury but kept getting recurrent erosions. She was actually scratching the cornea off with her fingernail all the time, and we then once caught her out. So she had no abrasion. We dilated a pupil to look at the fundus just to see if there's a glass inside, because she kept insisting there's glass. She was sitting for the pupil to dilate, came back in with a big abrasion, and then asked her what happened, and she says she has a habit of scratching the cornea. So all kinds of things can catch you out. After abrasion, we move to foreign bodies. Everybody is familiar with these little metallic foreign bodies on the surface of the eye, which you take out, and they're easy to remove. They leave a rust ring. The rust ring is always easier to take out within the next 24 hours. Usually on the day of injury, it's more difficult to take out the rust ring, but you can polish it off with a diamond burr. When you see something like this on the cornea, these vertical lines or scratchy lines all over, I call that an ice rink cornea, like somebody's skated on ice, and usually indicative of a subtarsal foreign body. And in the patient on the right, it was a butcher with a bone spicule under the lid, and here it was a little metallic foreign body. Usually where the foreign bodies lie are in the subtarsal sulcus. Very rare for a foreign body to be embedded over there, but it can be. One has to look and invert the lid. You can be caught out, as one of my colleagues was. He sent me this patient with marginal keratitis, and what this patient had is a bit of plastic. You can see the angular nature of the material and the debris of mucus collected, and the blood vessels growing. So you can see it's been there for a very long time, and then all one had to do is take that superficial foreign body away, and the lesion heals. So think about foreign bodies. They can masquerade quite a bit, as you will see in this patient. This patient was sent with a dystrophy, diagnosis of dystrophy, which was wrong in the first place because it's only in one eye. And then we looked at it, and I'll show you what there was a linear, you'll see that in the video, a vertical area of haze, which actually looked like might be a foreign body and not something, but was very, very well epithelialized. So We tried to figure out what it is without causing much damage because we weren't very sure, but we suspected that this was a foreign body, very thin epithelium on it, which is coming off easily. And then when we found that you take a crescent blade and you scrape it, it just lifted off and came out. And you'll see that in a second or two. So clearly, these foreign bodies, which with all these various plastic materials around, they can stick on the surface and get embedded. The only mistake I made is I didn't keep that foreign body because it was so biocompatible. It was absolutely brilliant. So we knew what that was. We could have done something with it in the future. But there you are. So that's then leaves behind an abrasion. Blast injuries have foreign bodies which go deeper. The bottom right was a snooker cue injury. They leave behind fibers of the leather. And here you have to deal with these foreign bodies as appropriate. They may take months for all of them to extrude and they may never come out. So you can't go digging after them all the time. The ones that are embedded and inert, we leave them. The rest we have to treat, and sometimes in multiple sessions because there are so many. And like I said, always look at all the whole eye, not just the cornea, because the damage can extend way behind. Foreign bodies can be penetrating, and limbus is a common site. So this one over here is pretty obvious here in the bottom left, but the top right, we couldn't see anything anywhere, but he was certain that something hit the eye. And then when you do a sidal test, you can see right at the limbus, as a surgeon would do, that precisely the foreign body had penetrated the eye, and he had sort of wiped it off. And there was nothing in the eye, but there was. So one has to be wary of any different manifestation these foreign bodies may present with. If you have a thorn, then it becomes a bit more tricky because the risk of infection is high. And there are various strategies people have described to try and remove the thorn. And one is with a curved needle, engage the thorn and try and bring it backwards out of the epithelium. But what you see over here is a case where we had to actually go and pull it out internally because the thorn was almost in the top right picture in the slit beam. You can see was this is after it's been removed, so the thorn is not there, but it was more than halfway into the cornea and sticking into the anterior chamber. So we put a lot of heal on and then we took it out that way. But this is another nice picture of recently my colleague had to do this, and she just gave me these pictures. So that's the entry site, that line of this glass foreign body, which was sticking more than half into the anterior chamber. You can see that was the top limit and the rest was all in the anterior chamber. So when these things happen, it is not wrong to go in and try and take it out internally rather than try and go from the stroma. So here with the paracentesis, put a lot of heal on to make sure the eye doesn't collapse on you and the glass then doesn't penetrate into the lens or the iris. So stop the, then make a paracentesis wound in the direction that will be most convenient to grasp. And then here we're using some vitreous forceps, grasping the foreign body, and we're pulling it very gently internally. And as you pull it internally here on removing, what you have to do is make sure the entire tip of the foreign body is within your forceps. Here it broke on the way out because part of it was caught in the stroma, and then you just pressed the lower lip of the wound because it was half in the wound and the foreign body came out. So glass, if you lose it in the eye, is very difficult to find. So one has to be extremely careful with these foreign bodies. And there's just another one just to show you. This was a metal foreign body and the sidal negative because the foreign body was blocking the cornea, but we could pull it out on this occasion. But here, the point is that if you have a channel like that, and if it's a hot metallic foreign body, the tissue around it contracts. So it's very difficult. This patient was very drunk. We couldn't give him a GA, and this is under the yellow light of the microscope. The video quality is not good because he couldn't tolerate the bright light. But what I'm trying to show is that you can seal this track by injecting fibrin glue in it. And we tried different ways to inject, but eventually what worked was take it on a 30 gauge needle, the two components of the fibrin glue, and inject one after the other into the track. And if the bit goes in the AC, that's fine. It will seal. This comes in very, very useful, this fibrin glue, in a variety of conditions. There's a paper we published on it that you can read on the non-conventional uses of fibrin glue. Moving on to corneal lacerations now, there are the two types, the penetrating lacerations and the non-penetrating. So when you get a non-penetrating laceration, over here, if the laceration reaches the wound edge, then one has to recess the conjunctiva, and then one has to look at the conjunctiva, the sclera over there, to make sure that it's not extended beyond. And that's on the top right, so it's gone. You do your peritomy and you look, then you explore the extent, and you can see the sclera over there, and then you clean it, you put it back, and all you have to do is some tacking sutures. And the tip over here is always start with the point where the anatomy can align with the anatomy. You can see the limbus, and where it is the extremity of the wound. When you close the extremity first, then that becomes the extremity, and you close that, and all these sutures are in different directions. It's only because they are just to hold it in place, and they come out within a week, because then it heals, and you can see it's healed quite nicely. So the principle is clean, close, and cover. Here's another example of a non-penetrating laceration. The lamellae swell up like the pages of a wet book. If a book gets wet, unlike a wet book, you can never push it back together, but you don't have to try and stitch this. Just leave it alone. You don't even have to put a bandage lens. It will not sit properly because of that swollen area in the middle. As you can see, here's the hinge. Quite nicely you can see, and we'll come to the hinge concept in the next slide. But you can see how this one then settles, and eventually it goes back by itself. So all you have to do is just support it, make sure it doesn't get infected. Don't try to push it back in place. Nature will take its course. Now, when you do get a full thickness penetrating laceration, you try and ascertain the entry point in the cornea. Let's say that's the entry and the exit into the endothelium. And you draw that, and then draw a line joining the two extremities. That is the hinge of the wound. When the hinge is within that drawing, within your area of the wound, it is a self-sealing wound. Think of all your phacoemulsification incisions, and you draw a line across in any direction from one extremity to the other. They're all within. That's why they're self-sealing wounds. And here, if the hinge is outside the area of the wound, it is not a self-sealing wound, and one has to suture it. And this one, the one on your left, you can observe. So here is one. You can see a penetrating injury, and the hinge is within. There's a sidal positive, and you can see that here the trajectory of the wound all the way from epithelium to endothelium. And this one sealed on its own. There's fluorescein. It's not leaking. You don't need to do anything. Here's another triangular wound. You can see this is a larger view on your right of the left, but the hinge is outside. This is leaking, and this has to be sutured. So what are the principles of suturing for lacerations? Like I said, examine the extent of the wound, and then suture from the periphery towards the center, and always keep the suture perpendicular to the point of application. Perpendicular to the point of application. The distance between two sutures should be less than the length of the suture, otherwise the wound will leak. So here is an example of how not to do it. All over the place the sutures are, and one mistake here is you're burying the knot in the wound. Never bury the knot in the wound in a corneal wound, because when you take out this suture, it will just rip the wound apart. So have the knot at one end or the other end, but never in the wound. You can see the distance here is too far. Some sutures are longer, some are shorter, some are going in different directions. And when you can see this suture, you can see only one line. That's a good suture. When you can see both the lines, that means it's not a good suture because it's not perpendicular or vertical. So you should only see one black line for each stitch, and that tells you it's been placed rightly. So like I said before, always start from the periphery and move towards the center, and it's perpendicular to the point of application, doesn't have to be parallel to the next stitch. And you move inwards, and as you close from out to in, then everything falls into place. So if you try and align the middle first, and if you get it slightly wrong, all the rest will be wrong, and you get fish mouthing. So start from the periphery as it like a zipper, and it'll close. So you have two zips coming from the periphery to the center. They will close it and it'll fall into place. Now, if it is a vertical wound, you go equidistant on the two sides. But if it's a shelving wound, you go longer on the underriding edge of the wound and shorter on the overriding, because most of the wounds are shelving, and you don't want the one side of the wound to slip over, like this. You want it to slip over onto the other side. So you want them to fall in place like that. So it's important that you don't go equidistant, because that's what will happen if you do that. So longer on the underriding edge and shorter on the overriding edge. For triangular wounds, the thing changes a bit. You have to direct the sutures towards the base of the wound like this, and they're not perpendicular to the point of application. And if it's hyperacute, you put a suture on the top like a onlay stitch to keep the apex down. And if it is acute, you can put a stitch there. If it is a stellate wound, you do the same principles, but you can then take a purse string suture, which you can tighten the wound over here and then just pull it outside, because this suture is going to remain buried forever. And if there's still a leak in that, then you take a bit of that orange blob, which is the fibrin glue, and try and seal the wound with fibrin glue. And like I said, it doesn't matter if the glue goes in the anterior chamber. It helps, in fact, to seal it. It will absorb. It's like fibrin in the AC, following any uveitis or any infection, that fibrin is natural, it dissolves. These are some examples over here of the suturing. The only point I want to make here is when you've taken all the sutures out, there's a big scar. Don't rush for a cornea transplant. Always do a rigid gas permeable contact lens trial. And the true visual acuity you will only know when you put a rigid gas permeable lens on and then give a pinhole. A pinhole on its own will not give you the true visual potential because of the extensive irregular astigmatism. Again, some more examples over here of various kinds of sutures. I won't go through them in the interest of time. But the last point I'm meant to make here is that you can have a penetrating injury with no sidal sign, or sidal negative, because of a blood clot, which is, as you can see here, sealing the wound. And when you get blood in the anterior chamber and the pressure goes high, it's very dangerous, because you can cause blood staining of the cornea, and that doesn't go away. Only a cornea transplant can help visual restoration over there. So try and avoid high pressures, and you might have to evacuate the clot. The problem with blood in the AC, as we know, with hyphema, is the rebleeds. So you have to then give them the antifibrinolytic agents like tranexamic acid to try and stop the rebleeds. So here's the same patient, and here's the blood staining that happened in one other patient, the cornea. So in summary, always examine the whole eye, not just the trauma site. When in doubt, glue or stitch. Always cover with topical and or systemic antibiotics, especially when using a bandage contact lens. And this point I didn't make during the talk, but is very important. No matter how multiple or shredded the cornea, be multiple lacerations or shredding of the cornea, don't debride any tissue. Like a jigsaw puzzle, try and put all the bits back into place, and then suture them with overlay sutures, direct sutures, or just a bandage contact lens to keep them in place. Because the moment you debride even a small shred of tissue, that cornea will heal with scar and cause extensive irregular astigmatism. Never bury the knots in the wound for reasons I've told you. Explore the extremities of the corneal wound to make sure it's not extending into the sclera, and remember to check the pressure. Thank you very much.
Thank you so much, Professor Dua. That was a very to-the-point talk and explaining all the niceties of corneal trauma, right from abrasions to lacerations, in very simple words for anyone to be able to do. I would now request our treasurer, Dr. Santosh Bhide, to introduce Dr. Rajesh Fogla. And then we will have, we will be taking questions at the end of all three talks. This is for the audience.
Thank you, madam. Good evening, everybody. Our next speaker is Dr. Rajesh Fogla. He is specialist in cornea, cataract and refractive surgery. He is trained in Shankar Netralaya. He has keen interest in lamellar corneal surgeries, ocular surface reconstruction and infection. He is actively involved in teaching and training at various national as well as international conferences. He has numerous publications in peer-reviewed journals, and he himself is a reviewer at different prestigious journals. He has received awards at American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology. He has received many gold medals and many orations at national conferences. Dr. Rajesh Fogla, please.
He has also been made fellow of the Royal College of Ophthalmologists recently.
Yes. Yes.
Thank you. Good evening, everybody. I would like to thank MOS for giving me the opportunity to be part of this webinar. The topic that I'm going to talk on is approach to corneal ulcer. And corneal ulcer is a sight-threatening clinical condition, and the patient often presents to the general or the comprehensive ophthalmologist first with symptoms of pain, photophobia, blurred vision, and discharge. Before you examine the patient, in the history, I think it's important to look at the specific risk factors. Trauma is quite common, especially with foreign bodies, as Professor Dua had alluded to. This can be because of riding two-wheelers without wearing a helmet, or in the bus or train, sitting at the window seat, you can get foreign bodies getting into the eye.
It's not extended beyond, and that's on the top right, so it's gone. You do your peritomy and you look, then you explore the extent, and you can see.
There is a background noise. That's okay. The other risk factor is contact lens wear. If your patient has positive history of contact lens wear, always remember to collect the contact lens solution and the contact lens case as well for microbiological evaluation. Any prior surgery like a cataract surgery or a laser refractive surgery can also be a risk factor for developing a corneal infection. Compromise of the ocular surface because of dry eye, limbal stem cell deficiency, neurotrophy, local or systemic immunosuppression, and medication toxicity. This is also quite common because whenever patients develop symptoms, they always self-medicate. This may be either with decongestants or sometimes with topical steroids. And this can, although initially reduce the patient's symptoms, but often results in severe infection. In terms of the etiology, the common organisms that we see in our clinical practice are either bacteria in the urban setting and fungi in the rural setting, but it can be because of a viral etiology or parasitic or atypical organisms as well. When you see the patient, it's important that you document. This can be either in the form of making clinical drawings, or you can take photographic documentation. This is very important because you can document the severity of the disease, and it can also help assessing in the response to therapy, because sometimes it may not be possible to remember each and every detail of the patient at all follow-up visits. Microbiology, if you have a very small peripheral infiltrate less than 2 millimeter in diameter, these can be empirically treated, but lesions which are larger than 2 millimeter located in the central cornea or are pretty dense with a significant amount of thinning, these are sight threatening, so you should scrape. It's important that if the patient is already on a lot of medications, sometimes stopping the medications for 12 to 24 hours can help improve the yield, especially in culture. And don't take the exudate which is over the ulcer just for your microbiology, because that will not give you any organisms. You can gently remove the exudate using a cotton bud, and then using a Bart Parker number 15 blade or a spatula, you can scrape the edge of the ulcer. Don't go to the thinnest point because you can have a risk of perforating, but go to the active edge of the ulcer and take scrapings, which you can initially send for slides, especially for KOH smear to determine whether this is a fungal positive or a fungal negative. Other stains can be the grams or GMSA. And in culture plates, the usual culture that we do are the blood agar, chocolate agar, subarachnoid dextrose agar, DHIB. And if you're suspecting acanthamoeba, you can go with the non-nutrient agar or the low-instant Jensen medium. Diagnosing between infective and sterile. Infective, the symptoms are more severe. The lesion is often central. The anterior chamber reaction can be moderate to severe, usually associated with the epithelial defect, and the progression is rapid. The sterile are mild, peripheral, don't have an epithelial defect, and the anterior chamber reaction is also not very severe, as you see in the photograph. In terms of treating, when you start antimicrobial therapy, you can, depending on what you clinically suspect, you start with the antimicrobial therapy. Loading dose can be given. You can initiate every 5 minutes for 30 minutes, thereafter 1 hourly for 24 to 48 hours. But after that, you can use it for every 2 hours. The exception would be a fungal keratitis where you're treating with natamycin. Natamycin has poor penetration. So if I am treating a fungal keratitis, sometimes I will resort to using 1 hourly till I see a clinical response. One should avoid a shotgun approach of starting all the antiviral, antibacterial and antifungal therapy all at the same time, because the medication toxicity will harm the ocular surface much more and will avoid a clinical response to the infection. You can assess the clinical response and modify therapy, and sometimes the microbiology results can also guide you into that. Systemic therapy with oral antibiotics, antifungal depends on the extent, if there is extensive involvement, perforation, or if the limbus or sclera is involved. Remember to use cycloplegics because of the intraocular inflammation. They will give relief to the patient. The infection is often associated with increased IOP, so address the intraocular pressure by giving intraoperative lowering medications. I usually prefer giving oral acetazolamide rather than topical medication unless there is a contraindication for systemic Diamox. Address the pain as well, because that is one of the main reasons why the patient has come to you. So that also should be addressed. The corneal ulcer also induces a lot of foreign body sensation. So sometimes adding a little bit of lubricant can also help, especially bland ointments can, and especially at nighttime application. And also if the systemic diabetes, you have to control the sugar levels, because if you don't control the diabetes, that can have an impact on the healing of the corneal ulcer. Give dark glasses. This will help reduce the photophobia. And if there is any thinning, you have to give a rigid eye shield so that there is no external pressure on the eye to prevent any perforation from the pressure. When you start the therapy, how do you realize that the ulcer is responding to your treatment? I think the first thing is the improvement in the symptoms. Every time I see an ulcer patient coming back to me, the first thing I ask my patient is, how did you sleep last night? And if my patient says, oh yes, I slept well, then I know that the patient is symptomatically much better. But if my patient says, no, I have not been able to sleep at all at night, and I ask them, do you have a headache or nausea? And if they say yes, that they have, then I am worried about the intraocular pressure related nausea or headache. Or if they have severe pain, then we need to worry about that something is not correct. Looking at the eye, you look at the edge of the infiltrate. Usually if there is a response, the edge will start becoming blunt. The density of the infiltrate will also start reducing. But mind it, sometimes there is tissue loss, melting, thinning of the cornea can also give rise to a reduced density of the infiltrate. Usually the corneal edema surrounding the infiltrate also starts getting better. The anterior chamber inflammation, especially the hypopyon, starts reducing. And if you stain the surface, you will find that there is reepithelialization of the cornea. So the epithelial defect starts reducing and there is reduced melting. Now, looking at specific symptoms like bacterial corneal ulcer, they are usually yellowish infiltrate. You have a rounded margin, conjunctival congestion, chemosis can be there. You have a very rapid course. The exudate is, you have a kind of gelatinous exudate sticking to the surface. The AC reaction, the hypopyon is a fluid hypopyon. That means it moves. It's not like a thick hypopyon. And they can often be quickly associated with corneal melt, decimeter seal formation. Usual organisms can be either the gram-negative Pseudomonas, Klebsiella, or the Staph aureus, Staph epidermidis, or the Streptococcus. Sometimes you get the atypical mycobacteria or the nocardia. Now, this is a young patient who had a minor foreign body falling in the cornea, had a foreign body removal done. And 2 days later, the patient presented with this kind of a picture. Just with 2 days history, a sudden onset, redness and a white spot developing with the hypopyon. And this is in the visual axis. So we scraped, we found it was gram-positive foci, treated with the 4th generation fluoroquinolone, responded very well because we got the sensitivity result later on. And this, you can see that it did not leave behind a large scar which could affect the vision. So a timely intervention in this case was helpful in resolving the condition. This is again a contact lens wearer who had a large infiltrate, again in the visual axis, corneal scraping revealed a gram-negative infection, treated appropriately with the fortified tobramycin and topical fluoroquinolone, and this patient also recovered very well. A fungal ulcer, in the clinical feature, the course is slightly less severe than what you see with a bacterial. Often they will have a history of trauma with a vegetative matter while working in the garden or in the farm. The appearance, it has a dry, rough texture with slightly elevated edges. Often there are satellite lesions as well, feathery margins. You have either the filamentous, aspergillus, or fusarium. You can have with yeast as well. And oftentimes there is another organism called the pythium, which was originally thought to be fungus, but now we know that it's not it doesn't fall into the fungal category. And the other thing, the demiticious fungi can have this pigmented lesion, which are often confused with perforation and iris prolapse. So this is again that you need to watch out for. So some of these infections with dematicious fungi like Corbularia can present with these dense pigmented plaques on the cornea. If you have this surface plaques, you can debride them gently with a number 15 blade. Topically, I like to use natamycin, which works very well for filamentous fungi. You can use topical voriconazole, especially if it's a slightly deep-seated lesion, because the penetration of voriconazole is better than natamycin. If you have candida, then amphotericin is better in this situation. And if the lesion is very large, progressing, or you have endothelial plaques or involving the sclera, then sometimes you resort to using systemic antifungals like ketoconazole, fluconazole, or voriconazole. Just to note that the time to resolution for fungal keratitis on an average can be somewhere between 35 to 40 days. This is a case of a fungal keratitis. You can see a large lesion, a plaque-like lesion, and it took almost 48 days for that lesion to become. So you have to be persistent. You cannot expect a response like a bacterial ulcer to respond in a couple of days and start showing the eye to get better. Sometimes you have these indolent infections in the cornea where the patient has a waxing and waning course, has been on a lot of medication, sometimes antibacterials, antivirals as well. And if you look at the lesion, like this is a nocardia keratitis, it has a string of pearls appearance where you look at the outer edge, you will see these tiny pinhead infiltrates, and the rest on the other edge, the ulcer is healing. And if you scrape it, you will see those branching filaments on the James stain. So you can
Hello, Rajesh? Rajesh, are you there?
Network issue probably.
Your voice isn't coming through.
Probably network issue.
Is there some network issue, Santosh?
I think so.
Maybe we can
technical person. You might have accidentally unmuted yourself. You might have muted yourself accidentally, Rajesh.
I'll check. I can unmute him.
No. I think his video is also frozen.
Yeah, his video seems to have frozen. It's.
I will just give him a call.
Network.
Yeah.
Yeah, network issue.
We'll just wait for a second or two.
Shall we start with Dr. Sangeeta's question, or should we wait for some time?
Or should we?
Let us see his response. We can take questions otherwise. Because then he can start out from here.
I think he's coming back. He's coming back. It's like. Because I'm seeing him, I mean, I've seen the screen at least. Beslin, can you try and help? Okay. Then maybe we can get on to Sangeeta's talk and take questions at the end.
Yes.
Shall we do that?
Yes,
Rajesh can continue from here, from where he left off. Sangeeta, is that okay with you? But the
thing is, we have to stop sharing his screen. Yeah.
Yes, he has to stop sharing his screen.
Yeah. That may not be possible. So she won't be able to share her screen.
Yeah.
So I think we'll take questions and answers. Questions we'll take. We'll take questions.
So just talk to him also. Just have a talk.
I will talk to him. I will talk to Rajesh.
Okay. So moderators.
I had just called Dr. Fogla. Actually, his number is forwarded to a resident. So he's giving the message to Dr. Fogla.
Okay.
Mr. Beslin, I can see there is one option at view options when you are viewing Dr. Fogla's screen, and it says that we can stop it. Yeah, correct.
Yeah.
Screen share is stopped now. Yeah.
Yes. I think now Dr. Sangeeta can share her screen.
Yeah. Sangeeta, you can go ahead now.
You want me to try that?
Yeah. Should I give her introduction then, briefly?
Yeah, please do. Definitely.
Yeah. Sorry for the interruption. It's because of the internet issue. We are sorry for that. Our next speaker is Dr. Sangeeta Va. She is a famous ophthalmologist from Maharashtra.
Hello.
Sangeeta, it's okay.
She is from Maharashtra. She has vast experience in ophthalmology for last 30 years. She is a rank holder at undergraduate as well as postgraduate level. She is trained in L.V. Prasad Eye Institute. She has done her fellowship in Cornea. And now she is a medical director of International Eye Bank at Ruby Hall Clinic, Pune. Dr. Sangeeta Va, please.
Thank you. I'd like to thank Dr. Sunaina Malik particularly and MOS for giving me this opportunity. And in fact, I'm honored to be sharing the evening with Professor Dua, who has always inspired me, and with Rajesh, who I learned so many tips on lamellar surgery. I'll be talking about the practical aspects of treating patients of corneal chemical injuries in our day-to-day practice, and I'm sure all of us in our practice do get such patients coming in. What one must remember is this is an absolute emergency, and the patient has to be taken in on priority. The most devastating sequelae of chemical injuries are the corneal melt, the tissue damage, the limbal stem cell deficiency, which can be sight-threatening, and the glaucoma, which very often goes unnoticed. So it's extremely essential to get an effective and accurate assessment right at the beginning, right from when the patient walks in, and monitor him for the days and months that follow. And this can only help to prevent the tragic consequences and improve the outcome for the patients. The patient has to be attended on priority and take him in before everybody else. Just make a brief note of the history to know whether it's self-inflicted.
Sangeeta, just a moment. Share your screen. Share your screen is not shared. Your presentation is
Please
not shared.
share your screen. Share your screen.
We can hear you, but your screen isn't shared.
Can you see it now?
No. Not yet.
Now?
No. No.
Your PPT is open.
Yeah, I know, but I don't know why I'm not able to. I did it a bit ago.
Go back to share.
Now can you see it?
No. No.
It's there down below, that arrow, green arrow.
Yeah, I know. I have logged in and I've.
But did you go to share? Yeah, now you start.
Yes.
Now you're on.
Not
Yeah.
yes.
Okay.
Perfect.
Yeah.
So I don't know now why it's not going on to a slide. Yeah, okay. So can you see it now?
Yes. Clear. Yeah.
Okay, so the patient has to be taken on priority. Just make a quick note of whether it's self-inflicted or an accident or an assault. A consent must be taken. If the patient cannot give the consent, take it from the attendant, or normally you have the employer or somebody coming in. Try and make a note of what the chemical is and whether it's a combined thermal or mechanical injury along with the chemical, like acid injuries, you know, the battery blast. Along with the acid, you will have particles coming in and explosions at the site of work. So it's important to know what exactly has got into the eye, assess the extent of the injury as much as possible, and start the emergency treatment in your clinic, even if it's a medical legal case and you don't otherwise treat medical legal cases, because this, again, there's like a golden hour in treating these patients. Once the initial treatment is given, you can take time and plan the action, whether it is in the scope of treatment of your own practice or you want to refer the patient, discuss the pros and cons and the prognosis with the employer and the patient and the attendant. So I would first anesthetize the patient and make him comfortable, make him lie down, quickly check his pulse, blood pressure if it's possible, start irrigation, copious irrigation for half an hour to 1 hour, intermittently, stopping every few minutes, and try and remove any particulate matter that is seen. Apply an antibiotic and you may patch the eye for comfort. Remember to check the vision and the intraocular pressure. If the vision is PL absent and the eye is rock hard, there's possibly a vascular occlusion happening, and this patient should be taken into the OR and an immediate paracentesis, IV mannitol, Diamox given to lower the IOP. Make the patient comfortable with analgesia, and sometimes they can go into a shock because of the pain, so this must be kept in mind, and keep the patient nil by mouth till further assessment. And according to the severity, either you continue treatment at your own setup or you refer the patient elsewhere. A chemical injury is always an accident, and most of them can be prevented with precautions. However, the incidence is significant, and it almost always affects adolescents, working class, young children, and women, especially the homemakers at home. And it can happen in the industry, in the agricultural field, domestic setups, acid splash. We must keep in mind assault, especially young women. And because of the carelessness of adults who throw around the tuna packets, you have little children who get hurt. So these are the different agents, and we know amongst the acids, the sulfuric acid and the hydrofluoric are the worst. As far as the alkaline injuries go, ammonium hydroxide and calcium hydroxide are the most notorious. When you look at the patient on torchlight, look at the lids, the face, see how much of the burns and eschar is there, assess the conjunctival epithelium, look at the corneal status, examine the limbus carefully, look at the anterior chamber, and remember to check the intraocular pressure. So here it is vital to remember to stain every patient of a chemical injury, because on torchlight it's very deceptive. You might miss a corneal defect which will show up only on a fluorescent stain. Assess the total area of the epithelial defect, the conjunctival defect, look at the ischemia. Ischemia is noted by the blanching of the limbal blood vessels that are seen. Look at the density of the corneal opacity or the edema that occurs, and assess the intraocular pressure and look for the lens. Professor Dua is going to pop up many times in my talk, and his is the most valid and rational classification, and it gives you an extent right from grade 1 to grade 6, where the older ones would stop at grade 4. So you would be, misdiagnosing a patient with good prognosis as a severe injury. You look at the limbal involvement in terms of clock hours, look at the conjunctival ischemia in terms of percentage of the cornea, the conjunctiva that is affected, and then you devise an analog scale and grade the severity of the injury. So like I said, the appearance of the cornea is deceptive, and this might look like an absolutely clear cornea, but on a blue filter, you will notice there's an epithelial defect here, and this is a totally debrided or de-epithelialized cornea. Make the patient look up, down, and in all gaze positions to assess 360 degrees. Like here, you have a blanching of vessels with limbal ischemia, which is more extensive in the left eye. You can also see these thrombosed blood vessels, which indicate the ischemia and the damage. Now, this patient, for example, on the left is a fairly good prognosis patient with just 3 clock hours of an epithelial defect. The conjunctiva is staining. That means there might be a defect, but you can see the blood vessels. So this is a good prognosis patient who can be treated with careful watch in a regular clinic and may not need a specialist referral unless some new complication occurs. Even this patient would be of a moderate risk, because under the lid, I don't have a picture of that, but the upper limbus was spared. And as we'll see later, he healed very well. Patients who come in like this with 360-degree melts, ischemia, ground glass corneas, or melts and perforations are very high-risk, poor prognosis patients and should be referred straight away. So the acid we know also causes similar changes like alkali. However, it doesn't penetrate as much as the acid, and that's why as the alkali, and that's why the intraocular damage is much less. It tends to denature the proteins and coagulate and precipitate on the surface, and that's why the penetration is less. But corneal collagen shrinkage can occur and shortening, and this is the one that causes the acute rise in intraocular pressure that must be watched out for. As against this, the alkaline pH causes saponification. The alkali binds to the glucosaminoglycans in the cornea. You get saponification of the fats, breakdown of the cell walls. The antigens are laid bare, and these trigger an immune response, release of MMPs and leukotrienes. The collagenase gets activated with the calcium, and the stromal melt starts, and the cycle continues. So stopping this cascade by timely intervention is the only way to prevent destruction of the tissue. Tuna is a big menace, and though it's thought that it's more often in the low socioeconomic group and the rural setups, we are seeing more of an urban menace. Besides chewing tobacco, it's used in Unani and Ayurvedic medication. It's ingested by even the middle class for so-called treatment of osteoporosis. It's applied to cuts and wounds for healing. And besides, it's used in the construction business. So tuna packets, which are just thrown carelessly around, and the poor quality plastic, makes these children more prone because they pick them up like water-filled balloons, and we know that they squirt into the eye when pressed. So the calcium prevents, it forms calcium soaks, and so it doesn't penetrate into the anterior chamber. However, it can penetrate into the corneal stroma and sclera after it stays in prolonged contact. And very dense opacification, scarring and cicatrization can result. So what is most important is when you see a child or a patient with the Chuna burns, he has to be taken immediately for debridement. The normal reflex when anything goes in your eye is to squeeze the eye. And when you squeeze the eye, the calcium or the Chuna gets pulled into the upper fornix. And that's why I think exploration of the upper fornix is extremely important. It's best to give a short general anesthesia in a pediatric patient or even sedation, sweep the upper fornix with double eversion, and you can irrigate with EDTA to chelate the calcium. Now, it's very easy to keep EDTA in your clinics. If you just keep 3 or 4 vials of the vacutainers where we collect blood for hemogram, each of these has about 1.8, so 2 vials are enough to give you a 0.1 molar solution diluted in 10 ml, and you can irrigate and prevent the calcium from acting on the tissues. So here when the Chuna was left, this patient would have healed up very well, provided the upper fornix had been cleared. And because the Chuna remained, you see these adhesions and the damage to the upper quadrant. So after the irrigation and chelation, you can apply amniotic membrane. This helps to helps epithelialization. It reduces the inflammation, scarring, as well as the vascularization, and improves the final outcome. So an amniotic membrane can be easily done. It can be applied with fibrin glue, or you can place sutures in 2 rows, Vicryl or nylon, whatever is available. One needs to remember that you have to assess the patient periodically because the proteolytic activity will make it dissolve. A bedside or a simple procedure, a device that has been innovated by Dr. Bhaskar Chaudhary is the Amserter, and it is used primarily for bedside AMG application in patients of Steven-Johnson syndrome and also in acute chemical and thermal burns. It essentially comprises of 2 acrylic rings in which the tissue is sandwiched. And this can be flexed like a contact lens and inserted into the conjunctival fornix. It will fill both the fornices and be retained in place. It can also be used to do a slit where you can sandwich the limbal cells in between 2 layers. So if the AMG is not available, one can do tenonoplasty, where you mobilize the tenons and pull it down and suture it right round to help in the healing. In case of a persistent epithelial defect, you can apply Gunderson's flap, that is, you mobilize the conjunctiva and suture it across. And finally, one can do a tarsorrhaphy. In the medical management, one must use collagenase inhibitors, oral doxycycline, topical steroids, cycloplegics, artificial tears, and anti-glaucoma medication. I think we've spoken about the EDTA. Some other agents that can easily be used are acetylcysteine, topical ascorbate, and oral tetracycline. All these are to be given till the epithelium heals up. Oral steroids should be initiated and given in the first 10 to 15 days. That is to reduce the migration of inflammatory cells and activation of the collagenases. However, if the defect persists beyond day 10, one must judicially either switch to low-dose steroids or stop them, because then they can worsen the corneal melts and the tissue damage. The intraocular pressure needs to be taken care of, and you can have a bimodal rise, either an acute rise or a persistent glaucoma eventually because of damage to the trabecular meshwork and persistent uveitis. The reparative stage starts from day 7 onwards for about 2 to 3 weeks. The blood vessels bring in all the growth factors, and the corneal ulceration will eventually stop when epithelialization and vascularization is complete. So here is a patient, I think the first one which I showed you, and this patient healed in about 15 days with no surgical intervention. This patient, in fact, he started healing really well. And so this was a race between the corneal epithelium sliding in and the conjunctival epithelium trying to go in. And when you find the conjunctiva growing in, you can do a sequential conjunctival epitheliectomy, again described by Professor Dua, and this would have eventually healed. Unfortunately, this patient was lost to follow-up and come 6 months later with a pseudopterygium-like growth. He eventually underwent a partial slit and recovered useful vision. The late reparative phase will go on for up to 6 months. It's important not to be tempted to try a reconstruction at this stage at 1 month post-op, because eventually he could scar into something as bad as this. So before doing any reconstruction, one must evaluate the posterior segment by an ultrasound. The ocular surface reconstruction basically has two aims. One is to restore the corneal limbus and the epithelial phenotype. Like here, there's a total limbal cell knockoff, and after a slit, you can get a surface reconstruction. In cases like the patient who I initially showed you, this patient would be a perfect candidate for what is known as a conjunctival limbal autograft, which you can take from the other eye, because once you release this, there'll be a bare bulbar conjunctiva. Placing just an amniotic membrane will not help because the adhesions will form again. So you use conjunctiva along with a bit of the limbus from the other eye, and he will heal well. The cultivated limbal epithelial transplants are almost obsolete now with the event of SLET, which has been, we know Dr. Sangwan and group have developed that. In case of bilateral limbal cell knockoff, you can use allografts either from living related donors or from cadaveric tissue. However, one must remember that they need systemic immunosuppression lifelong to prevent a rejection. A SLET, in very brief, after you do a keratectomy and a peritomy, you get a biopsy, limbal biopsy from the other eye, and apply an amniotic membrane to cover the bare area, and the limbal lenticule is cut up into little bits and it is glued in place. A bandage lens is put on and wait for the epithelialization. This is patient at 1 week post-op. This is at 1 month post-op. Here you can see internalization of some of the amniotic membrane, and either we could have done a PTK, but this patient's cornea was too thin. So she did really well after using a mini scleral contact lens. Once you have replaced the corneal epithelial phenotype, you restore the corneal clarity either by doing a deep anterior lamellar keratoplasty depending on the depth. Here the OCT will help you to gauge the depth of the scarring. If it's full thickness, do a PK, and if it's a very high risk with dense vascularization, or if it's a failed graft, you can do a K-probe. And we shouldn't forget that with the newer contact lenses, we have a lot of opportunity to avoid surgical intervention. This little girl, she was just 4 when she first got hurt. Again, her mom was practicing Unani medication, and she got tuna in one of her eyes. After multiple surgeries at the age of 8, we trained her, and today she wears her contact lens by herself, goes to school. She's achieved 6'12" to 6'9" vision and promises to be an ophthalmologist. So finally, in conclusion, we know that acids and alkalis cause severe and permanent damage to the cornea and ocular surface. The immediate and late effects are compounded by cicatrization and dryness. Restoration of the ocular surface is a big challenge, and counseling the patient and the family through the journey of multiple surgeries goes a long way in visual rehabilitation of the patient. Thank you for your attention.
Thank you so much, Sangeeta. That was a very nice presentation of chemical injuries, elaborating on the various aspects and how to rehabilitate also. I would now request Rajesh to please continue from where you left off. If you can share your screen. Can you go back to where you left off? Yeah.
Yeah, sorry, I got disconnected and then I was not able to join back because I think it's a locked group. So we were speaking about the nocardia keratitis. The other situation, what you can see is the atypical mycobacterial keratitis. These are again very indolent infections, commonly seen either after a refractive surgery or after cataract surgery. The infection typically occurs either under the flap or within the corneal tunnel that's been created. So these are two cases where you can see the infection, and usually treated with, again, with topical fortified amikacin, oral clarithromycin, and sometimes we give oral ciprofloxacin as well. This patient with the post-classic infection, you can see that we had to do a flap amputation because the flap melted over the infiltrate, and finally he did recover, used good vision, but the area of infection left behind a faint scar. The other infection which can present in the clinic is the acanthamoeba keratitis, often misdiagnosed as viral keratitis, and patient symptoms are more than the clinical signs. Pain is the predominant symptom, can be associated with contact lens wear, sometimes with laser refractive surgery or ocular trauma as well. The treatment is usually with biguanides, either polyhexamethylene biguanide or the chlorhexidine. These drops are not commercially available, but most of the major tertiary eye care centers do prepare the drops, and one can request from these centers. This is again a post-PRK, a patient who developed an infection, was treated with topical antibiotics for a long period of time. When we scraped, we found that it was an acanthamoeba infection, treated him appropriately, and it took about 6 weeks, but then he recovered well, but there is some amount of ectasia because the cornea had thinned down. But using a contact lens, he was able to regain about 6/9 vision. This is again a patient who had acanthamoeba infection. We were treated for a pretty long period of time, but despite the medical therapy, he was not responding completely. So in this situation, before it reaches up to the sclera, where associated scleritis and the limbal inflammation can make corneal surgery and the chances of recurrence very high, we went ahead, did a deep anterior lamellar keratoplasty, and we were able to achieve a good clinical outcome in this situation. The other uncommon corneal infection which can happen are the microsporidial keratitis. It has two variants, either the keratoconjunctivitis, which has a painted on appearance like these epithelial lesions, which are self-resolving. Sometimes you can debride the lesions and the infection would go away. The second one is seen in immunocompetent patients, where it presents as this fluffy stromal infiltrates, again with a waxing and waning course, because often misdiagnosed as immune-mediated herpes disease and treated with steroids. It gets better, but once you stop the steroid, the lesion tends to come back. Medical therapy is usually not very successful, so often these patients require surgical intervention. So this is a patient where we were able to do a dal right up to the decimus membrane, and we were able to the pre-decimus layer, and we were able to get rid of the infection. But every infection, so every infiltrate that you see in the cornea need not be infected. So this was a patient who had neurotrophy and had lagophthalmos as well, and you can see that the area of the lagophthalmos had a corneal ulcer. And so this patient was basically, we scraped just to rule out that there is no infective etiology, especially fungus. And we treated with topical antibiotic ointment using polymyxin, chloramphenicol, ointment, lubricants, and tarsorraphy. And this patient recovered very well. So you don't have to be very aggressive in treating. It's important to stain the surface with fluorescein, and you can pick up these viral epithelial keratitis much better if you stain. If you don't stain, sometimes these can be missed. The herpes simplex is the common infection that we see. You can see some of these lesions with herpes zoster as well, but not the terminal bulbs are absent. So the one on the extreme left is the epithelial lesion seen with herpes zoster. They are treated with topical acivir or ganciclovir. You can do epithelial debridement if the response to topical antivirals is not very good. And sometimes in immunocompromised individuals, you might need to consider starting systemic antivirals as well. They can present as stromal keratitis as well. If it is associated with epithelial disease, you give topical antivirals, otherwise treated with topical steroids and systemic antivirals. The other condition that the viral infection can present is the disciform keratitis, which presents as a disc of infection. And if you see with this sclerotic scatter, you can see the large keratic precipitates behind the area of the edema. They require topical steroids and systemic antivirals, and usually they respond very well. Sometimes the infection, even while you are treating it or at the time of presentation, can present with a perforation. As you see in this case, this was a patient with fungal keratitis undergoing treatment, but the area of thinning developed a descemetocele and it perforated. So this will require a cyanoacrylate glue application, which is not very difficult. You can, if there is already a perforation, there is fluid leaking out. So you first try and put a air bubble in the anterior chamber, which will tamponade the perforation so that the fluid egress is suppressed. And then you clean up the area where you're going to apply the glue, because if you don't do that, the glue is going to fall off pretty early. So you clean that using a dry Mersol sponge, you remove the epithelium. And the cyanoacrylate glue, you can take a small disc of plastic. Usually if you have a small dermal trephine, 2 millimeter or 3 millimeter punch, you can see there we are gently, we don't want the air to leak out. So we gently dry the surface, the surrounding loose epithelium can be pulled back, and then you can use a forceps to remove that thin strip of epithelium from behind. You can use a fine tine forceps. There you can see that the epithelial tissue or the exudate that's sticking to the edge is removed. And then the disc if you take a cotton bud, apply a little bit of ointment to it, and then pick up the small plastic disc, put the area of perforation and apply. And then that's the application of the glue, and let it polymerize for 15-20 seconds. And then the small, apply a drop of antibiotic, and then the plastic disc can be removed. If you can apply directly using a 30 gauge cannula in a tuberculin syringe as well, just that the surface becomes very irregular when you're applying it directly. Using this small plastic disc to apply, you ensure that the surface remains nice and smooth. Any excess spillover cyanoacrylate glue can be, you can trim it either using the forceps or a pair of honest scissors, and then you apply a bandage contact lens on the surface of the eye. So that's the post-op appearance, immediate after application of the glue. And this is at 6 weeks, you can see the glue has fallen off, the ulcer has healed well, and this patient did not require any corneal procedure. But if the disease is very extensive, or if there is a decimetocele or a frank perforation, sometimes at the time of infection or as the infection is resolving, this may require a corneal transplantation procedure. So at that point of time, you have to refer to a tertiary care center. So basically, in conclusion, a systematic approach is essential to managing a corneal ulcer. You identify the possible etiology and initiate appropriate therapy. Avoid starting, all the medications at the same time, because often we find that it's the medication toxicity that's hurting the eye more than the primary infection. And if you feel that with your therapy, if the infection is progressing too rapidly, or there is thinning, or there is a risk of perforation, I think it should be, or you don't have a clinical appropriate microbial diagnosis, I think it's important that you refer them to a center where they can either do a proper corneal biopsy or a microbiological diagnosis, or if there is any surgical intervention to be required, it can be performed. Thank you. Thank you for your patient hearing.
Thank you so much, Rajesh. Very nicely put. I would now request our secretary, Dr. Vardhaman, to please introduce our two moderators before we go on to taking the audience questions. Vardhaman, over to you.
Thank you, ma'am. Friends, after we have had extremely knowledgeable talks by all the speakers, now we are going to move on to interactive session, and that is going to be moderated by our moderators, Dr. Ranjana Pandey. She is associate professor at in the Department of Ophthalmology at BJ Medical College in Pune, with a special interest in cornea. And the second moderator is Dr. Sumit Lahane. He is assistant professor of ophthalmology at Sir J.J. Group of hospitals. He has had he's a fellowship trained cornea specialist at Narayan Nethralaya. So over to Dr. Sumit and Dr. Ranjana Pandey, madam, for the further moderation. Thank you.
Good evening, everybody.
Good evening. Thank
I
you.
have got one question for Dr. Dua sir. Sir, there are any tips for corneal tears associated with ruptured lens? How to go for these cases?
Right. So
we commonly see such type of cases in our hospital, corneal tears with lens rupture.
Yeah, so what you do is you make sure there's nothing trapped in the corneal wound, then you repair the corneal wound, and then you go and do the lens as is appropriate for the case. So if the rupture is with protein coming out and there's a big rhexis in the tear in the capsule, you try and do usually this trauma is young patients, so you can aspirate the lens material. I try not to put a primary implant in these patients. We leave it aphakic or try and preserve as much of the capsule as you can. We'll find often the posterior capsule is intact and it's just the anterior capsule that's ruptured. Then you can try and convert it into some kind of a rhexis, aspirate the cortical material, and then leave it till, because the way the corneal astigmatism is going to resolve will be different, and the lens you're going to put in will be determined by the astigmatism that's left. You can help these patients with a toric lens. That's why I tend to avoid putting a primary lens, and you might even have to do an iris fixated lens rather than an in the bag lens. It's not so easy to put one in the bag when it's all scarred up or it's damaged. So those are the options. That we have on one occasion, we have put a plano lens inside, just to keep the configuration of the anterior segment more normal, and then come back and did a piggyback toric lens with an iris clip. So you evaluate the situation as it is and deal with it, but those are the principles.
And sir, my next question is, how to remove deep intrastromal vegetative foreign body? In India, we have got trauma with jhadu, and that the broom, and the broom particles, they go inside the cornea and they go quite deep, and they are neither in the anterior chamber, they are you can catch superficially.
Yeah, so these ones, obviously the risk of inflammation and infection is high. So some of them, if you leave them, they will cause a lot of inflammation. So the approach to these is, which I didn't show, I mean, for us, they're not that common, but we make a flap of the cornea, and you go really deep and dissect the flap till you reach the material which you can grab hold of, and then you pull it back out. And if it's a very deep flap, you have to stitch it in place, but otherwise just with fibrin glue, you can keep it back and it tends to heal. So that's the approach for that.
Thank you, sir. So my another question is, if you have a laceration with tissue loss, at times you get a trauma where you get a punched out tissue loss of cornea, and then rest of the area is torn. So how are...
Yes. So I deal with that in my in a 30-minute talk. So 20-minute talks, I left those out. So what you do, if that laceration is, usually it happens with hot injuries, or we have had a policeman was hit in his face with a prisoner who had a ring, like one of these phantom ring, which they twist. It drills a hole in the cornea with a lot of tissue loss. So you can do either a tectonic graft, or you can do a combination of suturing and gluing. And if it is at the periphery, very, very much at the periphery, then you do a full thickness, well, just circular, make it regular, the wound in the cornea, which is full thickness hole anyway, and a lamellar thickness of the rest of the circle on the sclera. So you've got a sclerocorneal bed, and on that you put a 4 or 5 millimeter, usually 5 is better, becomes a little fiddly to handle anything less, a disc of cornea with the endothelium intact, because part of it is going to cover the corneal defect and part will be lying on the scleral bed. So you leave the endothelium and you stitch it. And we've got some good examples, which I didn't include in this talk, where it does cause a lot of distortion of the cornea. And then you go back and do a PK to sort it out. So there are those kind of strategies. So combination of sclerocorneal bed with corneal graft and or stitching and gluing.
Thank you, sir. Thank you so much.
Can you take the audience question? One of the audience questions.
Yes, ma'am. Like one of the questions are already answered here, that what to do in cases of lacerations with the tissue loss. and sir did advise a tectonic graft. There was a question that can we consider a primary PK if there is a tissue loss is huge, more than a punch out defect?
Yes, I mean, obviously, if it is huge, then that is the way forward, because otherwise you lose the eye. But the one question we didn't, when you say tissue loss, just similar to that question is if you get iris prolapse. Now, if you have iris prolapse in the wound, which is quite common with lacerations, that is a way of not corneal tissue loss, but the eye tissue loss. So when I was your age and we used to be taught, it always any prolapsed iris has to be excised. But I don't do that. What I do is I look at the viabilities, which means if you touch it and it's bleeding, means it's viable. Sometimes it's not viable. It's been there for a while and becomes a big lump and you cannot push it back in. So you try to reposit it if it is viable and recent. Otherwise, you excise it. And then you will be left with a hole in the iris that you can deal with that later. So that is my approach to the iris loss. But yeah, it's very valid to do a full thickness graft if the situation demands. But bear in mind, you tell the patient that this may not be the final graft, because often the material you will get in a hurry is not of good quality, and it may be just holding the eye together. So you decide your objectives. You know, my objective is what? Is to save the eye, then to restore vision. So if it is save the eye and restore vision, you need the proper approach or the proper donor material. Otherwise, the first thing is, you know, you can save the eye and then come back later.
Dr. Dua, there's one question from Mansi from Surat, in which she's asking if there is a large epithelial defect, would you advise local steroids or would you wait for some of the epithelium to regenerate before starting steroids? What are the take of all three of our speakers on this?
Yeah, so what happens is that you evaluate the extent of associated inflammation. So following a chemical injury, there is a lot of inflammation and a large defect. Following acute hypoxia with contact lens, there's a lot of inflammation with epithelial defect. So there you have to treat the inflammation. So for chemical injury and for acute hypoxia, I will start with steroid day one, no matter what the size of the epi defect. But if it is a traumatic abrasion, which is affecting only the epithelium, and even if it's pretty large, I will not start steroids day one. I will just treat with the lubrication, antibiotics, perhaps a bandage lens. But there, what helps most is a closed eye. If you can keep the eye closed, you know, we've forgotten the art of how to do pad and bandage. Remember that you're doing with only the tape and not the bandage. You make a 1.5, you know, fold one. What you don't want to happen is the eye to open under the bandage, under the pad. That will cause a lot more damage. So you have to close it, fill the orbit with the folded pad, and then another on the top, and you stick it. You can also do it with a shield, and I think what is Rajesh was mentioned about the shield on the eye. Now, what people do is when they put a shield on the eye, it should sit on the bone. But if it is mounted on the pad and it's not even touching the bone, any injury to the shield will go straight to the eye. The whole idea is if it sits on the bone, and when you hit the shield, the pressure goes on the bone. So very important. I've seen so many, even here you will find, you know, it's no different when people don't know, they don't know. You'll find two patch and then a shield right on the top. It causes more harm. So steroid only if there's good, you want to treat the inflammation, steroids, yes. Otherwise, it does delay wound healing. In the context of chemical burns, as Sangeeta told us, it causes enhancement of proteolysis because it inhibits the tissue inhibitors of proteases. So, but in the first week to 7 days to 10 days, I always use steroids. And then if it's melting, I backpedal.
What about you, Rajesh? What is
I completely agree with what Professor Dua. The only thing I would add is unsupervised use of steroids is not advisable, because in our setting, what happens is sometimes the patient is supposed to come back 2 days later. You give some steroids and you want to see the patient, and then for some reason the patient continues to apply the drop and comes back 2 weeks later. So, you know, if you have any doubt that the patient is not going to comply, then don't use unsupervised steroids.
And also the secondary glaucoma issue is a significant. The darker the skin, the more the likelihood of being a steroid responder, and that happens. people use steroids and they don't stop. They come back with blind eyes. We've seen that.
So, Professor Dua, that probably brings out a light question, is that what about iatrogenic epithelial defects that we create in surface ablsions, for example? So would you
Sorry,
start
I
steroids?
can't hear you. Sorry, what was the question?
Like in surface ablations, when we
Yes.
create epithelial defects, so would you
Yes.
start a steroid on day one, or would you wait for the epithelium to heal?
See, if you're doing a PRK, the tendency there is, and even the two situations, cross-linking and PRK. So there is a huge science behind epithelial stromal, which is keratocyte interaction. The more the ablation you do following PRK, you take the epithelium off, then you do your laser, the keratocytes get activated. That's why in LASIK, we don't see that. The epithelium is not healing. The more the epithelium is healing, the more cytokines they're releasing, which are wound healing cytokine. We also call them pro-inflammatory cytokines. The keratocytes get activated and you can get a haze, and that is variable from patient to patient. So the steroid there is to avoid the keratocyte activation and consequent haze. In cross-linking, because you have also done a similar thing, you have not ablated the stroma, you've taken the epithelium out, but you have done your riboflavin treatment with UV light to the stroma. Keratocyte apoptosis is well known with cross-linking. And that's going to be replaced by more keratocytes. They're going to be activated, you get haze. So to stop that, you will use steroids. The epithelium then becomes a secondary issue because that will heal, but the haze is difficult to reverse in these two situations. And we use prednisone 0.5%, which is prednisolone acetate, preferably 0.5%, and 2 to 4 times a day. After we start with, for cross-linking, we give regular twice a day Predsol and the antibiotic and a bandage lens to all our patients.
Thank you. Thank you,
Rajesh, one question to you. You spoke of microbiology in the context of corneal ulcers.
Sure.
Speaking from the point of view of solo practitioners, you know how patients are. It's okay in an institution where you're working or in a government medical college where you have the facility of the microbiology department with you. But in private practice, you will find that most patients are not willing to get that done. In which case, what would you recommend? Which initial antimicrobial would you recommend? Let's consider a bacterial ulcer.
Yeah, if you look at a bacterial ulcer, and if it is not in the visual axis, then you can monotherapy with the fluoroquinolone is okay. And if you suspect that it's in a hospital setting that the patient has got an infection, or you're suspecting MRSA, then maybe you'll give topical vancomycin. Or otherwise, for a gram-positive or 4th generation fluoroquinolone should work. If you're suspecting a gram-negative, they have found that both Cipro and ofloxacin have slightly better effectivity than compared to the Gatti and the Vigamox, the moxifloxacin. Yeah. But if it is something in the visual axis, I think fortified drops are something that I prefer.
I was just going to ask you that about fortified drops.
Yes. They are not very difficult to prepare. So we usually use fortified cefazolin along with fortified tobramycin. But I think microbiology becomes very important because most of the time that you see the patient, at least I see in my practice, they don't come to me after the primary. They're already visited 2 other doctors and they have been on several medications. And the clinical picture, when you look at the eye, sometimes you're not able to look at the eye and decide whether it looks bacterial or fungal. And without doing a microbiology, you don't even know which direction you're going to go. And it's something like shooting in the dark. And even if you're in a solo practice, I think it's always better that if you have a practice where you do see corneal infection, you can tie up with a microbiologist and, you can have the microbiologist explain to them because sometimes the microbiologist may not be in tune with what is prevalent in ophthalmology. And then you can specifically make a request of what you see clinically, at least the direct smear if they can see, and at least give you that whether they see fungal filaments or they don't see. So you will not bombard the patient with a lot of medication. If they don't see fungal filaments, then don't give antifungals because all these medications do have toxicity and they affect the response to the therapy that you give.
Another point I would like to drive home through this webinar is most people in practice tend to, you said cycloplegics, they tend to use cyclopentorate, which I think
which is not either homatropine or atropine.
Yes, absolutely. Because if it's a case of uveitis or a corneal ulcer, you need something stronger than cyclopentorate, definitely. Because cyclopentorate.
Yeah, well, I agree entirely. You got to use atropine. First of all, we use atropine, but then you can maintain it with cyclopentorate, or you don't have to give atropine all the time for 2 or 3 weeks. But get it nicely dilated, and then you can 3 times a day or 2 times a day, 1% cyclopentorate. That's what we do. With regard to dilating the pupil, again, and Sangeeta might have mentioned this, that don't use adrenergic agents in chemical burns, because there's already a lot of ischemia, and then you will cause more vasoconstriction and more ischemia to those vessels that are left. So that's also important. For one of the things about culture is, I think I agree entirely with what Rajesh is saying, that you have to culture, the patients in practice as much, if not better, than those who are not paying. So you have to link up. But there are some caveats. Now, we did a study for 5 years, patients who were admitted. So these are all severe sight-threatening ulcers. And we looked at a culture positive and we looked at a culture negative. Bear in mind that, if you are the best place in the world, you might get only a 60% positive rate, culture rate. There's a huge negative rate. And then we looked at the outcomes of those who were positive and negative, treated exactly the same, with one aminoglycoside, which is usually gentamicin or amikacin, and one cephalosporin, which we use cefuroxime. And what we found, these are both dual fortified because they were sight-threatening, and we found absolutely no difference in the outcome of those that were culture positive and culture negative. So the reason is because we have very little fungal and we have very little acanthamoeba, maybe not as much as bacteria, but more acanthamoeba than fungal. So for your situation in India, I think because if it's fungal, you have to get that information.
Yes, absolutely right. Because we do get a lot of fungal ulcers in our setups with
your fungal is more than bacterial.
Depends region-wise, yes, but yes, fungal should be in the range of about 40%, I would say.
Yeah, wow. That's quite a lot, yeah.
Talking about the keratitis, sir, I have a question here. Like, you showed very beautiful pictures of contact lens-induced keratitis healing in a stage-wise manner. Do you consider use of steroids, topical steroids, in any of this phase where it is healing, or do you consider it for the reduction in the scar size?
I'm not a big fan of topical steroids, but if I'm pretty sure that I'm dealing with a bacterial ulcer and my initial therapy has already resulted in good healing of the surface, then sometimes if there is still persistent inflammation, maybe I will use some topical steroids to provide better symptomatic relief and to maybe reduce the amount of, the overall scarring that may happen at the end of the, especially if they are in the visual axis. But that would be towards the end when the response has already, I would say 80% response has already been there. And then we can gradually, give some topical steroid, but just maybe twice a day, not very frequently. The temptation is always there to add steroid, but I think you have to be very careful.
Yeah. So I've just one comment on that. So, in certain situations, like if it's in a cornea graft, second or third commonest reason for bacterial keratitis in my setting is a previous corneal surgery with sutures and suture-related infection. So there you want to preserve the graft as well. And unlike any other part of the body, the problem with the cornea is that you can get a very good healing or treatment of the infection, but you end up with a scar, like Rajesh said, and then that's no good for vision. So you have to treat both the infection and the scarring or prevent the scarring. So the way I deal it is, as soon as I get documented response to treatment, I will never start steroid day one. I will start my antibiotics. And as soon as I can tell that this patient is responding, and Rajesh had the list there, reduced pain, reduced discharge, some vision improvement, reduced edema, reduced inflammation. When I know that there is a documented response, I will start steroids. So that will be usually within 48 hours. I will start by 48 hours or so, because I want to reduce the inflammation, and I know I'm top of the infection with my antibiotics. And then you have to be very careful because it can bounce back on you very quickly. So you have to be able to monitor these patients on a daily basis to make sure it's not. And only in that kind of situation, I will use steroids very early.
I have question to Dr. Fogla, sir. See, we get lot of patients who come from so many doctors. The ulcers are around 6 to 7 millimeters. They do not respond to treatment. So to do therapeutic keratoplasty, for how many days we should wait?
No, I think the question is that, do we have a diagnosis? So sometimes when I see a patient who's on multiple medications, when I see on the day one, maybe I'll stop all the medications, just put them on one antibiotic ointment, something nighttime, they apply some lubricants and see them the following day. Often I find a lot of my patients, when they come the next day, they say, I'm already feeling much better. And by the time we then may formulate a plan as to whether you need to do a repeat scraping, if it's a deep lesion, whether you want to do a small corneal biopsy. So if you can obtain a diagnosis and you can then give effective therapy, that would be my approach to that. But if it's a resistant organism, or if it is despite all the medications, it is not responding, then there is no point in waiting till the ulcer reaches the limbus, because once it reaches the limbus, then it's like a lost battle. So if you find that when you see the patient, you start therapy based on your clinical judgment and it is not responding, then I think I will go ahead and do a therapeutic PK while I still have some margin where I can do the therapeutic PK. Don't wait for it till it becomes like a corneoscleral graft, because then the post-operative problem of secondary glaucoma and closed angle and all those things will make it very, very difficult to rehabilitate at a later date.
Dr. Fogla, there is one allied question to this. Like when we are talking about non-responsive keratitis, what is the current evidence and the role of having cross-linking treatment to treat those ulcers? And when would you actually think about that?
At the same time, a lot of the continued with the medical therapy as well. So the cross-linking is supposed to strengthen the collagen, prevent the collagenolisis, and prevent decimetal seal formation, perforations. So in bacterial keratitis, or with superficial infections, it seems to work, but it may not be a great idea for deeper infections in the cornea. And you also have to watch out for reactivation of viral infection, because there have been reports of reactivation of viral keratitis following
herpes, especially.
Well. Yeah.
So one other option here is, which has been reported in the literature and also in my experience in very few cases, if you glue or stitch an amniotic membrane on the cornea and carry on with the same antibiotics to which he is not responsive, they will respond. And that is quite difficult to understand why. And the theory is that the amniotic membrane concentrates the antibiotic and delivers it to the site better. In vitro studies have shown it even works for viral antivirals, but for bacterial, they have shown this in patients, and I have 2 cases or 3 cases where nothing was working, and then I did this amniotic membrane, stuck it and put it on, and it worked. So that is one option. And then for we do cross-linking for when everything else fails. I would never use it as a primary treatment without antibiotics. Although there's an international trial going on that. But what one has to bear in mind is one sign that happens when you do cross-linking for these severe cases, the next day the hypopyon almost doubles. The hypopyon becomes very large and you think, oh, I've made it worse. But actually that's a reaction to probably all the dead organism, because see, the ultraviolet light also damages the bacteria. And you're getting a huge oxidative stress response, which can kill the organisms as well. So, and it's a immune response to that. That's the theory behind this increased hypopyon. So we've had success in some patients where nothing else has worked, and we've carried on. But like I said, we haven't stopped the antibiotics. We carry on with the antibiotics they were not responsive to.
But it's supportive in combination with antibiotics.
There is one question from audience to Dr. Sangeeta. The question is that, is ascorbate and citrate eye drops are available commercially? And if not available, how to make them?
Yeah, so you need to make them using injection, the ascorbic acid injection that is available, and you dilute it to make a 20%. So like in Moisol, if you have a 10 ml artificial tears, you remove 2 ml and add 2 ml of the injection ascorbate. It's normally available in all the pharmacies of the multi-speciality hospitals.
But just to point out, citrate and ascorbate are not mutually exclusive. Citrate neutralizes polymorphonuclear cells, which are the main cell and bring the most enzymes that digest the cornea. So citrate is for that, and you give it 4 to 6 times a day, and you need it in the acute stage. After 2 to 3 weeks, you don't need it. Ascorbate is because the vitamin C levels in the aqueous humor is several times higher than the serum. Very important for maintenance of the collagen, the ground substance of the cornea. And they drop precipitously following chemical burns, whether it's alkali or acid. And you have to replace them, otherwise the collagen will just collapse on you. So if you give oral vitamin C, 1 to 2 grams a day, you can't overdose because it comes out from the kidney. And we used to do exactly like Sangeeta said, a lot of vitamin C drops 5% or 10%. And we used to make the nurse put it because the patient will never talk to you after you put 1 drop in the eye. It stings so much and you can achieve the same level by giving tablets. So we put citrate drops for the reason I said, and vitamin C tablets orally. And that brings up the aqueous concentrations, and it also doesn't sting as much.
Sir, but how to get citrate drops?
Citrate, I think you buy it in India. I thought in India it's sold, in sodium citrate. I'm pretty sure it's.
I have never used the sodium citrate. I think the only one we get is the ascorbate, but I will check.
That's right. I'm pretty sure that we were asking our pharmacy where we can get it, and they're saying it can be sourced from India.
Any idea?
Find out a bit more, because our pharmacy makes it for us or they supply it, but we have a very regular supply when we need it. I will find out, because you can check. My understanding was always that you can buy it in India. There are a few manufacturers who sell it.
So when I just Googled citrate, it says fentanyl citrate and caffeine citrate.
Just put sodium citrate eye drops and see.
Sodium citrate.
Yeah, I know, but
maybe Rajesh may be knowing it.
No,
Rajesh can comment on it. Yeah.
Not use sodium citrate.
So in fact, I had done a short study in my practice, and we used the ascorbic acid as well as 2 groups with just the ascorbate and the ascorbate plus AMG, and of course the ones with the AMG did better. But eventually we concluded that it was the severity of the injury that correlated with the healing and not really the ascorbate. So obviously we were doing something wrong.
Yeah, I think the ascorbate is, if you look at, these are studies by Pfister, PFISTER, on the sodium citrate and chemical burns long back. And what is also interesting is that sodium citrate drops, and we're also using in severe corneal melts, because it's the enzymes that are digested. This is in bacterial keratitis I'm talking. So you can use, instead of doxycycline, you can use even citrate drops as an antiprotease. There are studies reported in the literature on that as well.
So I will search in the pharmacy, because I think they've mentioned that it's used as an anticoagulant, the systemic, the IV sodium citrate. So yeah, I'm sure if I ask some of my cardiovascular colleagues, they'll be able to.
They might be able to
find the source.
Pharmacy should be able to make it for you. Yeah, if it
maybe is blood bank.
Professor, here we make our own drops.
Oh, well, that's fine.
Sir, I have a question. That ascorbic acid you dilute in Moisol, and but the solution becomes more acidic because you are diluting a acid. The pH of that solution is always acidic. So you should
that's
have.
Why it stings.
He said
it should be near neutral, no?
It cannot be.
That's what he has told. No. He has told that it stings, so you give oral instead of topical.
No, they say potassium
Professor has already
got more pH than ascorbic acid.
Sorry,
Yeah.
I didn't get that.
Yeah, but I mean, it'll be different, like what Sangeeta said they've done. So I've done a lot of chemical burns here. I've never used ascorbate drops in the last 18, 20 years. In first 2-3 years I used it. I've stopped since then. Only tablets.
Maybe blood bank may help us in making acetate drops.
Sodium citrate is used for gout as well, so I think it should be available. Yeah, for making the urine alkaline, so it should be available.
Yeah, that's a point. That's a point.
But we need the injection to make drops, right? That is what we have to look.
Do we have any other questions?
Yeah,
Yes.
ma'am, there is one question. Sangeeta ma'am, limbal stem cell transplantation is one of very important thing that we do in chemical injury. So after the acute phase is resolved, what are the actual telltale signs where the ocular surface inflammation is almost nil when we plan this limbal stem cell transplantation? So what are those signs which we should recognize now? This is the time that we can go ahead with the limbal stem cell transplant.
So by the books, one should wait till the cicatrization is complete, and you would wait at least more than 4 to 6 months. I think with the newer diagnostic tools like doing an anterior segment OCT, you can actually visualize the surface and see whether it has scarred or there is continued inflammation in the form of haze or edema of the underlying tissue. And that is when one would go in and operate.
I think it depends on the severity of the primary injury. On an average, for a very severe chemical burn, I would wait at least 12 to 18 months before I even think about, because if you do it early, you're likely to have post-operative inflammation and recurrence of the symblepharon and loss of your limbal transplants that you have placed. So the longer you wait, the better the outcome you have. I would like to have Dr. Dua's.
I was about to say that myself. I was thinking whether I should add that or not, but I generally wait. So the way I do it is that if you look at the studies in the literature, that if you do HLA-DR markers and other markers for inflammation, you can see them in the burn corneas for up to 18 months. And these are mostly severe burns. So what I do is if I'm looking at an autolimbal graft or a living related graft, I definitely wait 12 to 18 months. If I'm looking at a cadaver graft, I might do it earlier, being fully prepared to repeat it, because inflammation destroys tissue. It kills. And if there is inflammation and you're putting something, chances are it might not survive, but it might serve a purpose for a short period. So if I'm using cadaver, there's a plentiful supply of that. I can do it again. But if it's living related or autologous, then I would definitely wait 12 to 18 months.
Thank you.
To all three of us, my question is, what is the use of albumin drops in chemical burns? Whether they are useful or not useful, because getting albumin is much easier.
Well, serum is even easier.
Easier. Yeah. Yes, exactly.
Same patient, and that has plenty of albumin.
Yeah.
But all these are what we call buffers. You want to buffer in the acute stage of injury. All your tissues are acting as buffer. So they trap the hydroxyl ions or the hydrogen ions, and they stop them from going in. So that all these you could use, and you can see there's fibronectin, epidermal growth factor, there is albumin, there's plasma drops, there's platelet-rich enhanced plasma drops, there's serum drops, a whole serum or 20% serum or 80% serum, all kinds. They all serve the same purpose. They facilitate growth of the epithelium, and they also neutralize and help to buffer the chemical. So you can use any one or two of them, whichever you want. It doesn't really make a difference.
There is a nice publication in the journal Eye. It's called the finger prick autologous blood, I think. So you use a 30-gauge needle and you prick yourself after cleaning the finger.
It was in the BJO by Abraham Kurian, who is a resident of mine in Nagpur. I remember it, but it's for dry eye treatment.
Dry eye, yes.
Yeah, that's fingerprint test. Well, we have just submitted, a massive review article. But we have this Cambridge symposium, which was on one very specific topic. I've given a talk on chemical burns there, and we've submitted this paper to Eye on management of chemical burns. And there is a flow chart in the acute field. We stick it in our casualty, which we've reproduced there, so that every person knows what to do. The most important thing, and Sangeeta mentioned this, is you have to put an anesthetic drop to open the eye, because these patients have blepharospasm or whatever. And you have to wash and open, because we have a nurse over here who patient was squeezing the eye and she washed for half an hour, the closed eye. So, people don't know even those simple things. You have to get the eye to open and wash it so that any fool can read that and tell. It's not very crowded, that flow chart, how to treat. So that's the kind of approach you should make these protocols, put them up so that it becomes second nature for anybody, any nurse, any ward boy, to wash an eye when the patient comes. The sooner you wash, the sooner you neutralize, the better the outcome.
I think we've had quite a number of questions now, and we don't want to keep the audience waiting for too long. They have an attention span. So if there are no further questions, moderators, are there other questions coming in or no?
No, ma'am.
Okay, fine. Then we've had a wonderfully interactive webinar, I think, with 3 such eminent speakers on cornea, which is exactly the way we wanted it. So I thank the 3 of you for joining us. And now I hand over to Vardhaman for the final vote of thanks. Thank you.
Thank you, ma'am. So I think the idea of this webinar by Maharashtra Ophthalmological Society was that our general ophthalmologists should have a lot of take-home messages. And I think that has been definitely delivered. And we are so happy and really honored that none other than Professor Harminder Singh Dua joined us, gave his time, and of course he's a global ophthalmology giant. We all know that, and the whole of Indian ophthalmology and Maharashtra Ophthalmological Society is really proud of him. So thank you, sir. Thank you for very simple, illustrative, and very resourceful talk for our Maharashtra Ophthalmic Society's member and all over India. We are also thankful to Dr. Rajesh Fogla and Dr. Sangeeta Wagh, our national speakers, who have been absolutely resourceful, and I think they have given a lot of tips and a lot of take-home messages for very common corneal issues that all of us face in general ophthalmology practice. I'm happy to announce that this webinar has been seen by close to 4,500 ophthalmologists. So basically, I think this has really reached where it should. So from Maharashtra Ophthalmological Society, we thank all the members because without whom I think this will not be successful. We thank both our moderators, Dr. Ranjana Pandey Madam and Dr. Subit, for interactive sessions. They really increased a lot of, brought out the best points from the discussions. And of course, we are thankful to our MOS body, Dr. Malik Ma'am, our president, Dr. Bide sir, Dr. Preetham. And I think we will meet for the next time, for the next webinar. The announcement will be done by Dr. Malik Ma'am soon. Thank you very much.
Our next webinar will be on 13 June. As all of you know, we have them twice in a month. Not too many to bore you, but enough to keep you interested. So the next one will be on 13 June. We'll let you know the topic very soon. That's
the big disadvantage to me of these webinars is that I don't get to meet you in person, shake your hands, and not get to eat any of the good food that is always available.
That's true, sir.
The carbon footprint is less and all the rest. But I have a webinar next month in the UK, and the company, the organizers have said, we are very excited. We have more than 100 registrants. 4,500.
This is India.
Tell them about our viewers.
No, that's why I said you have 4,500. Yeah, very well done.
So,
well, congratulations.
Sir, you can share the link.
And thank you. Yeah.
Thank you so much.
Thank you, sir. Thank you very much. Thank you,
Bye-bye.
Dr. Fogla. Thank you, Bhagwan.
Good night.
Thank you.
Good night.
Thank you, everybody. Bye-bye. Signing off.
Bye.